Alrighty, so today I'm just going to talk about introducing some perinatal mood disorders, and also at the end wanted to just start a discussion on how to support clients through the perinatal period. So the training and resources provided today are from Postpartum Support International, as well as I did attach different resources that I utilized at the end. So this is an amazing resource, not only for professionals, but also for perinatal clients. There's different resources that are available, not only to us, so specific trainings, but as well as just different support groups specific for clients. There's peer support groups that are free, as well as a helpline, and as well as access to different resources for them. So just wanted to include links to that just because that's a great way to support our clients that are going through the perinatal period. All right, so I wanted to talk about what are PMADs and kind of what it stands for. So first it starts with perinatal, which stands for the pregnancy and postpartum period. It stands for mood, so depression, bipolar, psychosis, as well as anxiety, which would encompass generalized anxiety disorder, panic, OCD, and PTSD, and then disorders, so impacting daily functioning. So this is a terminology change. So oftentimes you may hear clients or just people in general reference postpartum, which is not encompassing a disorder, that's just encompassing a time period. So postpartum is the time after giving birth. Oftentimes you may even hear a client of like, oh, I had really bad postpartum, but that's ultimately not what that means. They may be referencing like postpartum depression or postpartum anxiety, but I just wanted to kind of talk about that difference, and that it does not equal postpartum depression or postpartum. It stands for, it entirely encompasses all the different disorders, if that makes sense. So the prevalence, 1 in 5 to 7 women, there's a lot of variability there, as well as 1 in 10 men. So I wanted to talk about that too, that not only do women suffer from postpartum or any perinatal mood disorders, but also men can suffer as well. And I also did want to talk about the variability, as you'll see a lot of that just because according to the official journal of the American Academy of Pediatrics, every year more than 400,000 infants are born to mothers who are depressed, which makes perinatal depression the most underdiagnosed perinatal complication in America due to the lack of screening, and all the other barriers that kind of come with that. So there's a lot of prevalence, but not a lot of resources or information out there. So understanding the different terminology, the perinatal period is the time frame from conception through the first year after giving birth. So it takes into consideration any risk at any stage, including hormonal fluctuations in pregnancy, postpartum, so the onset of lactation, breastfeeding, weaning from breastfeeding, as well as the return of menstruation. Oftentimes, not always, but women can lose their period when breastfeeding. So with weaning comes the kind of return of that and all the different changes there. As well as the terminology prenatal or antenatal, which is just during pregnancy. Postpartum or postnatal is referring to the first year after giving birth. And commonly you'll hear the terminology, the 4th trimester, which is encompassing the 12 weeks after giving birth. So pregnancy is set up into 3 trimesters. So the 4th trimester is often that time that women will be referring to like in their maternity leave. However, most maternity leaves are typically around 6 weeks. And in the United States, sometimes no time is given at all. So theories of etiology, prevalence, and risk factors of PMADs. So some of the theories of etiology are biological, so hormonal changes in the perinatal period. So in pregnancy, there's an increase in estrogen as well as progesterone. And then onset of oxytocin and prolactin at birth. So prolactin is the hormone that's actually responsible for breastfeeding and lactation. And then another theory would be the psychosocial parts. So the vulnerabilities that are experienced during pregnancy and postpartum, which would include lack of sleep, genetic predisposition, as well as any social or environmental factors. Some of the evidence-based risk factors that increase risk for PMADs would be endocrine dysfunction, so diabetes, any history of thyroid imbalance, fertility challenges, PMDD or PCOS, any significant mood reactions to hormonal changes, so that could encompass physical pain, an abrupt discontinuation of breastfeeding, and then sleep deprivation. And then also evidence-based factors, which would be psychosocial. So any family or personal history of PMADs, as well as family or personal history of mood or anxiety disorders, and history of childhood sexual abuse is a evidence-based risk factor. So baby blues, I thought we would go over this and see if there's any questions here. You may have heard this terminology. There's variability here. However, it affects 60 to 80% of new mothers universally. It occurs due to the hormone fluctuations at the time of birth and with acute sleep deprivation. Lasts between 2 days to 2 weeks after birth, peaks 3 to 5 days after delivery. So common symptoms would be tearfulness, emotional lability, emotional reactivity, and exhaustion. So very commonly you'll hear like I was crying and I didn't know why. Overall, like generally happy. It's just like very much that overwhelm. It's with emotional ability. It's like that feeling of kind of like that immense sense of that pressure kind of at your shoulders. That's just kind of trying to get that release. Sure, some of us have experienced emotional lability before. And the difference between major depression versus baby blues would be the severity and intensity, the timing and onset of symptoms, the duration. And then it's very important to know that if symptoms persist after 2 weeks postpartum, this is not the baby blues. So it has a very short duration. And that's really important to kind of keep an eye on if you do have clients in the 4th trimester that are coming to you and saying, oh, I have the baby blues, but say, you know, they're on month 3 postpartum, then obviously that would be something to look at. So perinatal depression. So right now, perinatal depression as well as bipolar disorder are the only two that are actually specified in the DSM-5, which I'll go into later, but just wanted to point that out, that is of right now that they have a specific specifier in the DSM-5. So you'll look at kind of what I have listed here. This is what you would see for the kind of criteria that would be listed under major depressive disorder. So I won't necessarily go fully into it, but 5 or more symptoms during the same time. So I have the symptoms here listed, as well as they must include at least one of the symptoms should be either depressed mood, loss of interest, and it must cause marked distress or dysfunction. I also listed on here a different PDF that kind of goes into the background of even getting a specifier for perinatal depression. And I'll go into that a little bit later. I'm kind of jumping slides, but just wanted to provide more information about like the historical background of that kind of coming into it, as well as the advocacy that's been put in place surrounding kind of getting specifiers for perinatal depression specifically, rather than it being all encompassed under just major depressive disorder. I do want to talk about just how symptoms may present and how they may present differently than typically what we'd see under just depressive disorder. So some of what we may see is just general overwhelm, lack of feelings or connection toward the baby, inability to care for self or for family, feeling very isolated, irritable. It's very actually common to experience rage, could ultimately kind of be in there, agitation, as well as just the general sense of like, I don't feel like me. So more information, again, on the DSM-5. So a major depressive episode that begins during pregnancy or within 4 weeks after delivery is classified as peripartum depression. This term encompasses both prenatal and postpartum depression, which is a change, like I said, very beginning. Postpartum depression used to kind of all encompass. However, postpartum is only referencing after birth, not before. And depression can occur in both in pregnancy as well as in postpartum. The DSM-5 does not recognize postpartum depression as a separate entity. Instead, postpartum depression is included with the broader diagnosis of perinatal depression. And again, it's not its own separate entity, but it has the peripartum specifier. Any questions about that? And then again, I linked the PDF that has more about the history and advocacy there. They're really working to advocate for postpartum and peripartum depression to be considered the entire first year after giving birth rather than the first 6 months. So they're advocating for that specifically, as well as for more specifiers, meaning to have an OCD specifier, anxiety as a specifier, and to, again, have that encompassed in the DSM-5. So the different scales that we can use that are evidence-based. So most commonly is this first scale that I actually have placed here. So you can kind of look to see, this is a evidence-based scale for perinatal and postnatal depression. The screening's done at your postpartum visit. So if all is otherwise healthy, some of us may be familiar, but there is a postpartum visit that's done at 6 weeks with your OB. That is ultimately changing due to a lot of different factors. There's a lot of changes in the sense of wanting it to be sooner, because as you can imagine, 6 weeks is kind of a long time after such a huge life-altering event. And typically, again, this is done with your OB. And typically it's not really done necessarily for a check-in on how you're doing emotionally. It's just to see how you're physically recovering. And that would probably be more so along the lines of a vaginal delivery versus a C-section delivery. There may be more medical involvement and intervention there, but all around 6 weeks is typically when there's a visit and when this scale is performed. And then interestingly enough, the screening is actually done at pediatrician well child visits. Typically, when you bring your child in for these well visits, you'll kind of be handed this pamphlet, which will have, different information on kind of how is your child doing. And at the end, it will kind of ask about milestones and such. And that at the end, there will be this scale. And as well as the PHQ-9 is another scale that we can use that's evidence-based as well, that we're probably all familiar with. Many go undiagnosed due to the stigma surrounding the condition and patients' reluctance to disclose symptoms. So for instance, a lot of these screenings are being done 6 weeks postpartum and then not done again unless done at a pediatrician office. And as you would assume and probably think, the stigma that may be surrounded completing in a scale like this at your child's pediatrician office, like the fears of the implications of what if, this is to, somehow encompass or present in a way like that I'm not able to care for my child and whatnot. So there's a lot to unpack there. And in general, perinatal mental health screening is very low. So there's a lot of advocacy being done for universal screening, as well as not just screening, but education and referral to treatment. And a lot of that is, as far as being done with the whole education and referral to treatment, that part is really important due to the fear of like, oh, well, if I do have someone, especially a lot of these scales are not being done by mental health professionals, but by doctors of like, well, if I have someone that's scoring positive or very high in the scale, what do I do, right? So just kind of education for that as well. Any questions about the scale or even just like the screening done at pediatrician visits?
I think the main thing that just stood out to me is that this is obviously to measure depression, but like you said, having the OCD kind of panic add-ons being important, because even looking at like question 4 and 5 and even 10, like where it's like, I'm anxious, worried, feeling scared, panicky, thoughts of harming myself. Like to me, that would be a great segue into other measures versus I could understand some OBGYNs or pediatricians could look at this and be like, oh, you didn't like fully meet criteria for depression. You're good to go. So it can be a little misleading.
I agree with you.
Yeah.
I don't know, personally, I'm not sure if I love this scale. I remember filling it out myself, and some of the questions, I have been so unhappy that I've had difficulty sleeping. It's like, well, that may not be the case. I'm having difficulty sleeping because X, Y, and Z, right? So I feel like adding the PHQ-9 may help encompass more of the depression piece, as well as, implementing the GAD-7, which I talk about later. But yeah, there's no specific like perinatal standard at this point for anxiety as far as the scale goes there, as well as the well child visits. I was actually surprised personally that was done there more often. There's more check-in actually at my child's pediatrician office on how I was doing personally, rather than with my OB, which I thought was really interesting, and I'm pretty sure that's not just personal to me, but pretty universal experience.
Mhm.
So perinatal anxiety, like I was saying, the DSM-5 at this point doesn't have a certain specifier. So the criteria that I have listed is what we would find for generalized anxiety disorder, which, we're all familiar with. And with that, oftentimes in practice, you'll notice that the requirement for generalized anxiety disorder is at least 6 months. And in practice, there's a lot of discussion around that being diagnosable sooner, because 6 months, in my opinion, is a long time. Perinatal anxiety also tends to be specific towards certain topics. So health and safety of the baby is something that you may notice in your clients, kind of having those specific themes. And then with perinatal OCD, that would be intrusive, repetitive thoughts, so often obsessive thoughts, spiral of what if thinking. There's a lot of guilt and shame, feelings of horror surrounding thoughts, and mothers engage in behaviors to avoid harm or minimize triggers, so minimize compulsions. Common presentations of perinatal OCD would be fears of deliberate harm, contamination, accidental harm, ordering, arranging, and checking. And fears of deliberate harm, I think, was about 40% of the common presentations. So interestingly enough, in the training, they talked a lot about how it's actually very common for parents to experience intrusive thoughts. Around like over 80% of parents experience intrusive thoughts. And as we know, intrusive thoughts don't equate to OCD. So it's important to really engage in conversation and ask in detail, some of these assessment questions to kind of better assist our clients. I know for me personally, for example, an intrusive thought I had, which is strangely reoccurring anecdotally that I've heard of, waking up and thinking, oh, is my baby in the sheets? In reality, baby's sleeping right next to me in my bassinet. And for some reason, I have this reoccurring thought that this is happening. And again, the difference of just kind of paying attention that this client isn't experiencing it in a sense where it's persisting and distressing and kind of following around these different criterias. Any questions here? Often in some of the training, they talked about the actually misdiagnosing that goes on with perinatal OCD and the panic kind of that is elicited from providers in the sense of very quick to assume that that person is psychotic or experiencing psychosis from some of the thoughts that are described. And again, kind of why I wanted to talk about the difference and kind of what to look for, if at all, there was this presentation. So perinatal OCD, parents recognize thoughts and imagings as unhealthy or distressing. Extreme anxiety related to thoughts or images. Parent does not want to harm the baby. Thought is obsessive in nature, frightening and or odd to the individual, and parent has taken steps to protect the baby. Parent has no delusions or hallucinations related to the baby. And the difference with perinatal psychosis, parents may not recognize actions or thoughts as unhealthy. They may have minimal insight in or anxiety about the distortion of thoughts. Parent has delusional beliefs about the baby. Delusional thoughts may be egocentric, but not always. Those experiencing perinatal or postnatal psychosis may be disturbed by their thoughts, but compelled to act on them. And perinatal psychosis is always a medical emergency. So today I just wanted to kind of discuss on how we could support our perinatal clients, how to prepare and support clients through the fourth trimester or first year, and just any general questions. I know, again, I went pretty general with this, but more so I wanted to just have a discussion about how we can support our clients. I'm sure many of us, if not all of us, have worked with someone in the postpartum period or in pregnancy. So I was just kind of curious if anyone had any specific questions on supporting clients or even just feedback on your work that you could kind of bring to the discussion.
Are there like certain like treatments or tips or like in-session exercises that you have used that you find to be like helpful?
Specific to?
Maybe we could just say like, sorry, I wish you went back on the last slide, but maybe just like the depression. Oh wait, sorry, yeah, that slide. Maybe the perinatal psychosis. I guess you said that wouldn't be a medical, like more of an emergency state. So maybe the OCD would be more helpful of like things you might do in session to like work through this.
So I personally, they really emphasize this in the treatment of making sure that a patient is with someone that is specifically specialized in OCD. So they're getting the standard in treatment with that. And I personally do not have OCD training. So I don't work with anyone with OCD. I know actually Rachel and I have collaborated on a client specifically for this reason alone and making sure that that person has that expert, because CBT, ACT is not the gold standard, obviously, for treating OCD.
I can answer that a little because I currently have a client who she's struggling with perinatal OCD. For her, it's a little bit different because she has OCD like in general. So when she had her kid, it really wasn't that shocking to her or I. But I think the first thing that I really like to emphasize is that this is okay and like that this is normal and that these thoughts are just thoughts, because there is such a stigma around this. Yeah. And moms, I mean, you're going through so much, I can imagine, after giving birth, and then to start having these obsessive thoughts that are very terrifying. For her specifically, it's a lot of like potential harm to her baby. Like, what if I drown my baby in the bathtub? What if I forget that he's in there? Things like that. And so I always say like normalizing it first. A lot of psychoeducation around perinatal OCD can kind of just make the client feel a little bit more comfortable. And then exposures are always going to be the best. But I typically take these specific exposures probably a little bit more slower than any other like OCD with clients. Just because again, there's the baby that's involved and it can just feel really jarring for new moms. So for her specifically, you know, again, starting with the hierarchy, making a hierarchy of exposures and things like that, and just taking it very, very, very slow. But yeah, exposure is always going to be like the best here. And a lot of just like normalizing and validating and psychoeducation has seemed to be really helpful for this.
I know PSI actually has a specific like support group, peer-led group for this reason, because of this shame and stigma attached. And in the training, we actually had speakers and someone specifically that had perinatal OCD, ultimately talk with us and whatnot. And there was misdiagnosed, and kind of that overall then furthered the shame around it ultimately. So definitely appreciate that insight, Rachel.
So my question is, if we have a client who is looking to get pregnant or is pregnant and is like, I'm worried about this, what are ways for us to kind of prepare, if it's like a two-part question, like prepare them, prepare ourselves for this transition?
It's a really good question. And something that a quote that stuck with me is to focus more on your postpartum plan versus than having in your kind of focusing on your baby's nursery, which I feel like is kind of an interesting quote. But anyway, I think it's a matter of, I feel like there's embracing some of that uncertainty because you don't know until you know. However, at the same point, focusing on what are some of the controllables, things that, in the postpartum period, basic needs and kind of your hierarchy of needs change because you're caring for someone outside of yourself, frankly, for the first time. So some of getting your most basic needs can, become difficult. So kind of preparing for some of those things and also defining what your village looks like and knowing that your village can look different than, what someone else's looks like or what we would typically, define. So I think that's most important of like, what's your sleep going to look like? How are you and your partner going to navigate that? And that may look different depending on the person and situation, as long as what's your, leave going to look like from work? What's your support look like at home, at work, as well as even like food. How are you going to make sure that you have cooked meals, or how do you have access to food and things like that become difficult, especially in the fourth trimester, and kind of supporting clients in that way.
Okay. Yeah, I think that's like addressing the risk, some of the risk factors that you described at the beginning, because when I saw that, my thought was like, who wouldn't struggle with some sort of postpartum depression, anxiety, given that so many of those risk factors like occur, like not having any sleep, not having any food. I mean, that would cause most folks not to feel well. So I could see like having that proactive conversation. Okay, what does this look like? And then I'm thinking too, even like giving this quiz, like we all have access to this assessment. So even maybe just giving our clients it and saying, you can take this before the 6-week mark, before your OBGYN or pediatrician give it to you.
Right.
So yeah, so I like that, like coming up with a plan. And like you said, just putting that intentionality behind, like everyone else in your life can celebrate making the nursery, but I, as your mental health professional and counselor,
Right.
I'm going to talk about what does this look like and what are we going to look out for? And hey, take a look at the quiz right now, the assessment right now before you even start. And then also too, my other thought was perhaps even having the client have that conversation proactively with their OBGYN, because it sounds like, and through my experience too, that like a lot of OBGYNs may not even be aware of what OCD looks like. And so they may jump to, oh, this must be psychosis if this person's having this thought.
Right.
And,
Because they hear harm and then oftentimes there's reaction and then it's misdiagnosed, right? So it elicits fear. And there was a large percentage in the training where they had talked about clients being misdiagnosed.
Yeah. So even providing, unfortunately, the patient providing that education to their doctor, just like, hey, I want you to be aware of this in case I start to have these thoughts after delivery.
Well, even intrusive thoughts too, like knowing like a big reoccurring saying like good moms, good parents have intrusive thoughts, like kind of normalizing that, that it's not an all encompassing or reflection of you as a parent.
Mm-hmm. Mm-hmm. one follow-up question is, if a client of ours is wanting more information, like, is there any training for clients? Like, I know this training is for clinicians, but did they offer resources of like, hey, you can have them watch this video to give them more information on this?
Yes, I believe the website not only has access to that, but they also, I believe, to have like a postpartum like support, whether it's even before postpartum, where they may actually have like how to like, kind of set yourself up for the postpartum period, as well as just different resources and information. Like there's a get help section specifically to learn more, as well as resources specifically. And then there's more like urgent, like I said, a helpline that's specific too.
I know specifically the International OCD Foundation has, and I can put the link in here, like a really great resource for at least like perinatal OCD. And on like the page, they list like there's a interview with someone who struggled with like perinatal OCD and like talking about that, but they have like information for loved ones, like resources, clinical providers, like living with perinatal OCD that I've given to like clients before to just like kind of check out and like look at the page themselves. There's a lot of good stuff on that.
Yeah, I just also put in a link for the postpartum planning class that's available too.
I think this area that really requires clients to be working with someone that specializes in this. I guess I'm just not sure, like at what point you refer out if you're already working through, say, like symptoms of anxiety and depression with them, and similarly, like during, after the birth, if they're still experiencing things. I guess I just don't know. Do you think that this is pretty crucial that they be working with someone that's specialized, or a case by case?
I think it becomes crucial more so when it's like specific to OCD, where you would need that specialty, as long as you feel like you do have like the framework and capability of like treating the depression and anxiety, as well as just having a baseline knowledge. I think as long as we all collaborate together in that way, it wouldn't necessarily be a necessity, but I think it kind of comes down to your own comfort level too.
Yeah, and maybe even using the assessment measures to even see, like, if it's in I think our advantage to giving the client the assessment versus, again, like their physical doctor looking at it, is we get to look at each question and then dive into those questions. So if they score really high, to me, that would already start to signify like, okay, are we going to need extra support? Like maybe they're seeing me once a week. Maybe we need to call someone else in once a week as well. So they're doing therapy twice a week. Or, granted, you have to also look at the other factors. If they're not sleeping, not eating very well, then twice a week therapy might not be where they're at. But am I equipped to handle some of the severity of the specific questions? And like you were saying, Paige, especially if like those questions, some are pertaining to OCD, you'd be like, oh, well, that's kind of out of my wheelhouse. So let me just let the client know and then see where we go from there. Yeah, like, oh, good. Thank you for pulling that up. Let's see.
Is it typical for kind of OCD, like postnatal, to kind of just show up out of nowhere, or is there usually, like other signs and, like symptoms previous to pregnancy where it's like, okay, I have OCD and it's going to kind of transform, or is it something that can kind of come out of the blue from time to time?
I believe there's increased risk factors involved. I know in general, I believe this stat was actually year 1 to 2 times more likely to develop perinatal OCD, perinatal women, than the general population. As well as I think has a high comorbidity with depression as well. So more likely to develop if you are depressed as well. But I don't have the specific stat on that necessarily, but I know that there's definitely risk there. Any other questions?
You'll be able to share the slides with us so we can have those links for the resources.
Yes, I put them here at the bottom for resources.
Yeah, with the plan that you were saying, I think that's like such an amazing point. I didn't know, did you say you listed a bunch of the topics of discussion and like areas to focus on for the planning component, but do you use something specifically like a document or anything like that, or is it just general discussion?
General discussion, yeah. But it wouldn't be a bad idea to come up with.
I was gonna say, I'm like, I
not a bad
actually like this idea of creating like a handout, like a worksheet that we can provide clients who are pregnant or just right in that postpartum period.
Yeah, the topics that you mentioned were definitely great. I was just wondering if there was something that you reference with that, but yeah, no.
Yeah, it would be a good idea to like actually get a document, especially just to help you then understand and kind of remember like the differences. Not only are like, how are they taking care of themselves, but how are they taking care of baby, for instance? Like, are they breastfeeding? Are they formula feeding? Kind of understanding, just because those different things, obviously hormonally and as well as just logistically, impact how you care for yourself as well as how you care for your baby. So that would be a bad idea to kind of come up with a document that would also help the client, but then help you kind of have everything organized in that way.
Maybe like a postpartum roadmap.
Yeah.
Love that. All right. Thank you so much, Paige. This was wonderful. We will be having this posted in a couple of months. So hopefully by that point, we will actually have the postpartum roadmap, so then we can include that as a resource when this rolls out.
Sounds like a plan.
Right. Thank you again. Thanks, everybody. This was really, really helpful and already kind of has me proactively thinking about some of my clients in this situation or soon to be in this situation.
Yeah, if you guys ever have any questions, please let me know. There's so much to know, honestly, even around like the different pharmacology that's recommended for perinatal clients and things. So if you have any questions, shoot me an email. I'm happy to just discuss and collaborate.